Hey everyone, we're going to do a digital specimen walkthrough today, and remember we're going to be using Cardioscape. Cardioscape is a platform that we've designed and developed and produced to really serve as a free virtual cardiac anatomy education platform. And so we'll be using that today. We'll go ahead and scroll through some of the collection here. You'll see there's over 100 different digital models available of various hearts with congenital heart disease. We're going to go ahead and pick this one for today. If you're interested in downloading Cardioscape, just visit www.learnchd.com. Once again, that's www.learnchd.com. Entirely free. It's available for Mac and for Windows. And we're slowly developing a mobile platform, or at least mobile integration for this as well. But you'll see when we've clicked on this now that we have two 3D models that appear that have been generated by 3D scanning actual heart specimens in some of the collections that I've curated. We'll be able to see the defect both from the right and the left side, but let's go ahead and close one of these. And I will share that these 3D models have been made using a RevoPoint Miraco scanner, which allows you to really scan everything using the device itself and doing all the post-processing on the device itself. It really has become my go-to in these scans. But nonetheless, let's go ahead and look at this heart. The heart would have sat roughly in the chest as it's oriented here. Now if we go ahead and turn this heart, we'll see that there are pectinate muscles that spill outside the confines of the appendage. So that in fact means that this structure here is a morphologic right atrium. And when we look inside this right atrium, we do see the oval fossa, and we see that there's a large atrial septal defect in the confines of the oval fossa. So an oval fossa atrial septal defect. Now as we look at other parts of this right atrium, we see that there is a tendon of Totaro here, and that there's the mouth of the coronary sinus. The mouth of the coronary sinus and the tendon of Totaro are two of the three structures in the triangle of Koch, with the third being the tricuspid valve. Now we haven't examined this valve yet, but for the moment let's assume that this is a tricuspid valve. That would mean that the triangle of Koch would be formed by the border of the tricuspid valve, the mouth of the coronary sinus, and the tendon of Totaro. So the apex of this triangle would be right here, meaning that the atrioventricular node would be expected to be here. Now when we look at this right-sided atrioventricular valve, we find that it does have three leaflets. There's one here which has been transected. Here's a second, and then here's the third here. So we have three valve leaflets to this atrioventricular valve. This valve leaflet has direct connections to the ventricular septum, all consistent with the morphologic tricuspid valve. So here's the septal leaflet, here's the anterior leaflet, and then here's the inferior leaflet. Now when we look at this ventricle, we see that there are coarse trabeculations, and that there in fact is a septomarginal trabeculation here that gives off the cranial and caudal limbs. All of this is consistent with a morphologic right ventricle. So far we have concordant atrioventricular connections with right-handed ventricular topology. Now, what is striking right off the get-go is that both arterial trunks appear to arise from this morphologic right ventricle. So here's one arterial root, and then here's another arterial root. And so we do appear to also be dealing then with double outlet right ventricle. And when we follow these arterial trunks, we do find head and neck vessels. So the transverse aorta is here, the descending aorta going posteriorly, which means this is the ascending aorta, which makes this the aortic valve, and then this would be the pulmonary valve, and then the pulmonary trunk. Now, a common feature in the setting of double outlet right ventricle is an intraventricular communication, and here is an intraventricular communication, and we'll zoom in. We see that this intraventricular communication lives within the Y of the septal band, aka between the cranial and caudal limbs of the septomarginal trabeculation. And really, it sits immediately underneath the aorta. So this would be a subaortic interventricular communication. So more precisely now, we're dealing with double outlet right ventricle with a subaortic interventricular communication. When we look at this defect, you can see that there is a fibrous postero-inferior border here, and we can zoom in here. So here is the interventricular communication. The postero-inferior border actually is formed by the tricuspid valve, so it is a fibrous postero-inferior border, which just have some implications, as we know that the AV node will sit very close to the postero-inferior border of this VSD. And remember, once again, we'll expect the atrioventricular node to live right here. We've already identified that this interventricular communication is beneath the aorta, so is subaortic. And I purposely use the word interventricular communication because whenever there's overriding of an arterial trunk over a ventricular septal defect, there become two planes that can be closed. One is if you followed the putative ventricular septum directly parallel and close the defect there, which in the case of any sort of arterial override will not fully commit that arterial trunk to the appropriate ventricle or to even a ventricle, which would be problematic. So in fact, what the surgeons close is another plane, which is what we refer to as the interventricular communication. But now that we've discussed that, here is the aortic valve. You can't see all the leaflets perfectly, but here's one of the leaflets, here's a second leaflet, and here's a third leaflet. And you can see some of the sinuses here as well. The third sinus is not as clear. Here's the ascending aorta. And then here is the transverse aorta. And then going posteriorly, here's the descending aorta. We'll return our attention to the right ventricle now. And here we do see a pretty prominent pulmonary infundibulum. And here is the pulmonary valve. And it's hard to tell from the scan, but knowing this specimen and having dissected this specimen, this is in fact a 2-leaflet, 2-sinus pulmonary valve here. So now here is a pulmonary valve leaflet, and here's the pulmonary trunk, which gives rise to both branch pulmonary arteries. So we are dealing with double outlet right ventricle with a subaortic interventricular communication and some degree of pulmonary stenosis, I imagine, during life. Now here's that same heart. Now we're looking at it from the left ventricular aspect. Here we see a 2-leaflet atrioventricular valve, and I'll kind of zoom into its orifice here. You can see that these are fully interactive 3D models, so you can zoom and pan. Here's 1 leaflet, here's 2 leaflets, and then no direct connections between any valve leaflet here to the ventricular septum. So this left-sided atrioventricular valve is consistent with the morphologic mitral valve. You can see some of the papillary muscles here and here. This ventricle has fine crisscross trabeculations consistent with a morphologic left ventricle. Now you can see that as we look out this ventricle, the only egress from this ventricle is an interventricular communication that we've seen and studied in detail from the right side. You don't see an actual aortic outflow tract, you do not see the aortic valve from the left ventricle itself. And that's really it from the left side. But here is the left atrial appendage, and here is the transverse arch again, and the ascending aorta here. So an interesting heart with double outlet right ventricle, subaortic interventricular communication, and probably some subpulmonary stenosis during life.